Chun EJ, ETAL hypertrophic cardiomyopathy, assessment with MR imaging and multi-detector CT. Radiographics. 2010, 30-5-13-09-28. O'Donnell DH, ETAL cardiac MRI of non-ischemic cardiomyopathies, imaging protocols and spectra of appearances. Radiology. 2012, 262-2403-22. 8b. Pseudodiverticulosis. Esophageal intramural pseudodiverticulosis is a condition of unknown cause characterized by flask-shaped outpouchings of the mucosa that extend into the muscular layer and show characteristic findings on esophagograms. They are dilated excretory ducts of deep esophageal mucus glands resulting from obstruction of excretory ducts by plugs of viscous mucus and desquamated cells, or by extrinsic compression of the ducts by periductal inflammatory infiltrates and fibrotic tissue. It occurs in all age groups, predominantly in the 6th and 7th decades with slight male preponderance. It has been reported as a separate entity or in association with diseases such as diabetes, peptic strictures and esophagitis. Plovsic BM, ETAL intramural pseudodiverticulosis of the esophagus detected on barium esophagograms, increased prevalence in patients with esophageal carcinoma. AJR AMJ Rentgenol. 1995, 165. 165:1381-5. 9. C. Endometriosis. Endometriosis is a common multifocal. Multi 21-year-old woman with infertility undergoes US that shows a 2 cm right adnexal mass with posterior acoustic enhancement. Another multilocular cyst is seen in the left ovary. Further evaluation with Mr. shows multiple small lesions in both the ovaries and pouch of Douglas, which were hyperintense on fat-suppressed T1W images with shading sign on T2W images. What is the likely diagnosis? A. Dermoid. B. Endometrioid carcinoma of the ovary. C. Endometriosis. D. PCOS, polycystic ovarian syndrome. E. Pelvic inflammatory disease. 10. A young man presents to the ENT clinic with deepening of the voice. Going through his history and clinical notes, the consultant reviews a recent multifocal gynecologic disease that manifests during the reproductive years, often causing chronic pelvic pain and infertility. The ovaries are among the most common sites, 20%, 40% of cases. It manifests either as superficial fibrotic implants or as chronic retention cysts with cyclic bleeding, endometriomas. Endometriomas are thick-walled cysts with a dark, dense content that represents degenerated blood products. The cysts may be solitary or multiple, and they are bilateral in 50% of cases. Endometriomas may include peripheral nodules, blood clots, or fluid levels. In the latter, the non-dependent portion represents. Chapter 2. Test Paper 1, Answers. The freshest bleeding. A multilocular appearing endometrioma may consist of multiple contiguous cysts. Endometriomas are a marker of severity of deeply infiltrating endometriosis. On MRIs, cystic cavities can appear as simple fluid, with high signal intensity on T2, weighted and low signal intensity on T1, weighted images. They also may show high signal intensity on T1, weighted and T1, weighted fat-saturated images because of their hemorrhagic content. The shading sign, a common and unique feature of endometriomas, represents old blood products, which contain extremely high iron and protein concentrations. These hemorrhagic cysts typically show high signal intensity on T1, weighted images, and low signal intensity on T2, weighted images. However, endometriomas also may show variable signal intensity on T2, weighted images. Plain radiograph report of his. Chapter 1. Hands, which describe cystic changes in the carpal bones along with enlarged phalangeal tufts and metacarpals. What is the next appropriate imaging investigation? A. CT brain pre- and post-contrast. CHAMI LP, ETAL findings of pelvic endometriosis at transvaginal US, MR imaging, and laparoscopy. Radiographics. 2011, 31, for E77-100. 10. C. MRI pituitary pre- and post-contrast. The clinical history along with the radiographic findings points towards acromegaly, and in this case evaluating the pituitary gland for the presence of an adenoma along with correlating biochemistry blood profile would be appropriate investigations. Osseous enlargement of the vertebrae with increased AP diameter can occur with premature loss of disc space. Expansion of the terminal phalangeal tufts and metacarpals contribute to the clinical finding of spade-like hands. Other features include increased heel pad thickness greater than 25 mm, premature OA, posterior vertebral scalloping, prognatism, elongated mandible, sellar enlargement, and enlarged paranasal sinuses, mostly frontal sinus. In the case of pituitary macroadenomas, compression of the optic chiasm can often result in visual field defects. Brower AC, Fleming DJ. Arthritis. C. MRI pituitary pre- and C. MRI pituitary pre- and post-contrast D. Chest X-ray E. Lateral view of the skull. 11. A 77-year-old man with gradual onset dementia shows multifocal abnormalities on cranial CT and MRI. He has been recently diagnosed with amyloidosis. All of the following conditions may be present in central nervous system amyloidosis, except A. Occurrence in elderly patients. Brower AC, Fleming DJ. Arthritis. 2007:43-4. 11. D. Non-communicating hydrocephalus cerebral amyloid angiopathy, CAA, is an important cause of spontaneous cortical subcortical intracranial hemorrhage, itch, in the normotensive elderly. On imaging, multiple cortical subcortical hematomas are recognized. Prominence of the ventricular system and enlargement of the sulci representing generalized cerebral and cerebellar atrophy are nonspecific imaging findings. CAA should be considered in the broad differential diagnosis of leukoencephalopathy, high signal intensity of white matter at T2, weighted MRI, especially if associated with cortical subcortical hemorrhage or progressive dementia. Leukoencephalopathy may or may not spare U fibers. Chow CP, ETAL. C. Cerebral and cerebellar atrophy D. In the metaphysis. Metaphysis. This has distinct borders and lies in the intramedullary compartment. It is orientated along the long axis of the humerus. What is the most likely diagnosis? A. Aneurysmal bone cyst B. GCTC, simple bone cyst D. Chondroblastoma E. Non-ossifying 5/15/1731. 12. C. Simple bone cyst SBC affects the young, age 3-19 years, during the active phase of bone growth, and has a slight male preponderance M, F equals 3:1. They are asymptomatic unless fractured. They are commonly seen in the proximal femur or proximal humerus. They are solitary intramedullary lesions, centered at the metaphyses, adjacent to the epiphyseal cartilage during the active phase, and migrating into diaphysis with growth during the latent phase. They do not cross the epiphyseal plate. On a radiograph, they appear as an oval radial licency with a long axis parallel to the long axis of the host bone, a fine sclerotic boundary, and scalloping of the internal aspect of the underlying cortex. SBC appears as a photopenic area on a bone scan, if not fractured. Classic fallen fragment sign if fractured, 20%, centrally dislodged fragment falls into a dependent position. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011. Chapter 2. Test Paper 1, Answers. Non-ossifying fibroma. 13. A 50-year-old secretary presents with epigastric pain, nausea, and weight loss. She also complains of bilateral swollen ankles. She is referred for a barium meal as she is unable to tolerate an esophagogastroduodenoscopy, OGD. The examination shows thickened folds in the fundus and body of the stomach. The antrum was not involved. What is the most likely diagnosis? A. 13. Menetrier's disease. The hallmark of Menetrier's disease is gastric mucosal hypertrophy, which may cause the rugae to resemble convolutions of the brain. The thickening of the rugae is predominantly caused by expansion of the epithelial cell compartment of the gastric mucosa. Patients with Menetrier's disease most often present with epigastric pain and hypoalbuminemia secondary to a loss of albumin into the gastric lumen. Signs and symptoms of Menetrier's disease include anorexia, asthenia, weight loss, nausea, gastrointestinal bleeding, diarrhea, edema, and vomiting. The disease has a bimodal age distribution. The childhood form is often linked to cytomegalovirus infection and usually resolves spontaneously. It usually occurs in children younger than 10 years, mean age 5.5 years, predominantly in boys, male to female ratio 3:1. The second peak occurs in adulthood, and the disease in adults tends to progress over time. The average age at diagnosis is 55, and men are affected more often than women. A diagnosis of Menetrier's disease is made by using a combination of upper gastrointestinal fluoroscopic imaging, endoscopic imaging, and histologic analysis. On fluoroscopic images, Menetrier's disease is characterized by the presence of giant rugal folds. Rugal folds should normally measure less than 1 centimeter in width across the fundus and 0.5 centimeters across the antrum, and they should be parallel to the long axis of the stomach. Friedman J. B. Lymphoma. C. Eosinophilic gastroenteritis. D. Leiomyoma. E. Menetrier's disease. 14. A 58-year-old woman undergoes an echocardiogram followed by cardiac MRI for investigation of exertional dyspnea. The cardiac MRI was reviewed at the X-ray meeting, and the radiologist diagnosed concentric hypertrophic cardiomyopathy. Which of the following did the radiologist see? A. Thickening of the interatrial septum at and they should be parallel to the long axis of the stomach. Friedman J. et al. Best cases from the AFIP Menetrier disease. Radiographics. Radiographics. 2009, 29:297-301. 14. The thickening of the entire LV wall measuring 17 mm at end diastole HCM should be differentiated from other causes of symmetric increased thickness of the LV wall, including athlete's heart, amyloidosis, sarcoidosis, Fabry disease, and adaptive LV hypertrophy due to hypertension or aortic stenosis. HCM is associated with hypertrophy of the muscle to 15 mm or thicker. In cardiac amyloidosis, the amyloid protein is deposited in the myocardium, which leads to diastolic dysfunction and restrictive cardiomyopathy. Because amyloidosis is a systemic process, involvement of all four chambers is common, thus an increase in the thickness of the interatrial septum and right atrial free wall by more than 6 mm is seen. Dynamic enhanced MRI shows late enhancement over the entire subendocardial circumference. Sarcoidosis is a non-caseating granulomatous disease that infiltrates any area of the body. But most of the morbidity/mortality is from involvement of the heart. MRI shows nodular or patchy increased signal intensity on both T2, weighted and enhanced images, which often involves the septum, more particularly, the basal portion, and the LV wall, whereas papillary and right ventricular infiltration are rarely seen. Fabry disease is a rare X-linked autosomal recessive metabolic storage disorder. At MRI, the LV wall is seen to be concentrically thickened and delayed hyperenhancement is typically seen mid-wall, and has been reported in the basal infralateral segment. Differentiation between compensatory hypertrophy and HCM is sometimes difficult. In comparison to HCM, patients with compensatory hypertrophy usually have normal systolic function, rather than hyperdynamic systolic function in HCM, and their LV wall rarely exceeds 15 mm in maximal thickness. Athlete's heart can show increased LV wall thickness, but end diastolic volume and ejection fraction are normal. Another feature of the cardiac remodeling in athletes is the lack of areas of delayed hyperenhancement within the LV myocardium at dynamic enhanced MRI. Chun E.J., et al. Hypertrophic cardiomyopathy. Assessment with MR imaging and multi-detector CT. Radiographics. 2010, 30/5/13/0928. 15. C. Flame-shaped contrast seen in the perivesical fat. Sandler described 5 types of bladder injuries with conventional cystography. Type 1, contusion. Bladder contusion is defined as an incomplete or partial tear of the bladder mucosa. At 7 mm B, thickening of the entire LV wall measuring 17 mm, at end diastole center nodular high signal in the interventricular septum on T2D. C. Nodular high signal in the interventricular septum on T2D, thickening of the LV wall measuring 14 mm with normal systolic function. E. Thickened LV with delayed hyperenhancement of midwall. 15. A 50-year-old builder is involved in a high-speed RTA. CT is performed according to trauma protocol, demonstrating extraperitoneal rupture of the bladder. Which of the following best describes this? A. Contrast pooling in the paracolic gutters. B. Contrast outlining small bowel loops. C. Flame-shaped contrast seen in the perivesical fat. Mucosa. Findings at conventional and CT cystography are normal. Chapter 2. Test paper. Midwall and has been reported in the basal infralateral segment. Differentiation between compensatory hypertrophy and HCM is sometimes difficult. Fraction are normal. Another feature of the cardiac remodeling in athletes is the lack of areas of delayed hyperenhancement within the LV myocardium at dynamic enhanced MRI. Chun E.J., et al. Hypertrophic cardiomyopathy. Assessment with MR imaging and multi-detector CT. Radiographics. 2010, 30/5/13/0928. 15. C. Flame-shaped contrast seen in the perivesical fat. Sandler described 5 types of bladder injuries with conventional cystography. Type 1, contusion. Bladder contusion is defined as an incomplete or partial tear of the bladder mucosa. Findings at conventional and CT cystography are normal. Type 2, intraperitoneal rupture. CT cystography demonstrates intraperitoneal contrast material around bowel loops, between mesenteric folds and in the parcolic gutters. Type 3, interstitial injury. Interstitial bladder injury is rare. CT cystography may demonstrate intramural contrast material without extravasation. Type 4, extraperitoneal rupture. Extraperitoneal rupture is the most common type of bladder injury, 80%-90% of cases. Extravasation is confined to the perivesical space in simple ruptures, type 4A, whereas in complex ruptures, contrast extends beyond the perivesical space, type 4B, and may dissect into thigh, perineum, and propertoneal fat planes. Type 5, combined rupture. CT cystography usually demonstrates extravasation patterns that are typical for both types of injury. Vaccaro J.P., Brody J.M. CT cystography in the evaluation of major bladder trauma. Radiographics. 2000, 20, 513 7381. 16. An elderly patient on long-term dialysis presents to the orthopedic clinic with right shoulder pain. Plain films show juxtaarticular swelling and erosions of the humerus, but the joint space is preserved. MRI shows a small joint effusion and the presence of low to intermediate signal soft tissue on all sequences covering the synovial membrane extending into the periarticular tissue. What is the likely diagnosis? Vaccaro J.P., Brody J.M. Type 5, combined rupture. CT cystography usually demonstrates extravasation patterns that are typical for both types of injury. Vaccaro J.P., Brody J.M. CT cystography in the evaluation of major bladder trauma. Radiographics. 2000, 20, 513 7381. 16. A. Amyloid arthropathy. Amyloid arthropathy most typically affects the shoulders, carpal bones, and hips in a bilateral fashion. It is typically associated with long-term renal dialysis, which results in deposition of the beta-2 microglobulin. Affected joints demonstrate subchondral cystic lesions with juxtaarticular swelling. The presence of low to intermediate signal soft tissue within and around the joint clinches the diagnosis, as this represents the signal characteristics of the deposited proteins. Cf. Other inflammatory/infectious arthropathies, which tend to produce higher water content than soft tissue changes in the joint. Joint space is also typically preserved until the late stages of disease, similar to gout. A. Amyloid arthropathy. B. Calcium pyrophosphate deposition disease, CPPD. D. Pigmented villonodular synovitis, PVNS. E. Reticuloendotheliosis. 17. A 33-year-old woman with recurrent episodes of optic neuritis with waxing and waning upper limb weakness is referred for an MRI brain with high suspicion of demyelination. All of the following are Mr. features of acute multiple sclerosis, MS, lesions of the brain, except A. High signal intensity on flare. B. Black hole appearance. C. Incomplete ring-like contrast enhancement. D. Increase in size of lesion. E. Mass effect. Dannert W., Radiology Review Manual, 6th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2007:45. KISS E. ETAL dialysis-related amyloidosis revisited. AJR AMJ Rentgenol. 2005, 185:1467. 17. B. Black hole appearance. MS lesions can occur anywhere in the central nervous system, but are most common in the periventricular white matter. Typical lesions are ovoid, with the long axis perpendicular to the ventricles. They are better seen on PD and FLAIR than on T2 weighted images because of increased lesion CSF contrast. Lesions of the corpus callosum, at callosocceptal interface and subcallosal striations are characteristic. FLAIR is less sensitive than T2 weighted images to infratentorial lesions occurring in the brain stem and middle cerebellar peduncles. In the acute phase, lesions show increase in size and solid or ring enhancement with for contrast, which can persist up to 3 months, but generally resolve in weeks. Large acute lesions with associated edema. Mass effect and incomplete ring enhancement can mimic glioma, tumefactive MS. MS lesions show reduced magnetization transfer ratio, MTR, reflecting decreased myelin content. MTR is also reduced in normal-looking white matter, representing occult tissue damage. Such occult tissue damage is also detected by diffusion tensor imaging, showing reduced fractional anisotropy. Low-signal lesions on T1, weighted MRI, black holes, brain and spinal cord atrophy are seen in established MIS. Adam A. ETAL Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:1337. 18. D. Frog leg lateral of the hips diagnosis of SUFE, slipped upper femoral effect. 18. A 14-year-old boy complains of left knee pain and limp. He also has medial thigh pain. On examination, he has full range of movement with some discomfort on internal rotation. AP and lateral X-rays of the knee and femur are normal. What is the next investigation? A. CTB, bone scan. C. Epiphysis is made using anteroposterior, AP, pelvis and lateral frog leg radiographs. CT is rarely needed, although it is very sensitive. MRI depicts the slippage earliest, and MRI can demonstrate early marrow edema and slippage. It is also useful in identifying pre-slip changes in the opposite hip and shows differentials, for example infection, tumor, synovitis and so on. Although some institutions obtain a frog leg lateral view, it is possible to further displace an acute or acute-on-chronic slip when the hips are placed in this position. Thus some institutions avoid them unless the request comes from an orthopedic surgeon. Phraseology is important in all investigation-related questions. While the next investigation is frog leg lateral in several/most places, the best investigation, or the most appropriate examination would be MRI because it will provide the most information and cover all differentials. Bowles CA. C. MRI-D, frog leg lateral of the hips E.U.S. 19. A 30-year-old woman presents with shortness of breath and fatigue. CT shows enlargement of the right atrium, right ventricle and pulmonary artery, and normal appearance of the left atrium. What is the most likely diagnosis? A. VSD ventricular. Differentials. Bowles CA. 19. B. ASD atrial septal defect. LALV VSD uncomplicated ASD with shunt reversal, Eisenmenger syndrome, mitral valve disease tricuspid. (19) A 30-year-old woman presents with shortness of breath and fatigue. Bicuspid aortic valve D, coarctation of the aorta E, mitral valve disease. 20. A 50-year-old man is referred to a gastroenterologist. Gastroenterologist with a 6-month history of intermittent epigastric pain and nausea. He is referred for a barium meal test due to a failed OGD esophagogastroduodenoscopy. The study shows an ulcer along the lesser curve of the stomach. Which of the following is a malignant feature of a gastric ulcer? A. Adam A. et al. Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:427-9. 20. B. Karman meniscus sign. The Karman meniscus sign is a curvilinear lens-shaped intraluminal form of crater with convexity of crescent towards the gastric wall and concavity towards the gastric lumen. Gastric ulcer sign. Benign malignant crater, round, ovoid, irregular, radiating fold, symmetric, nodular, clubbed, fused area, gastricae, preserved, destroyed, projection, outside lumen, inside lumen, ulcer mound, smooth rolled edge. Karman meniscus sign. C. Hampton's line. D. Central ulcer within mound of edema. E. The ulcer depth is greater than the width. 21. Which of the following characteristics is typical of prostate cancer? A. Low on T1, high on T2B, low on T1, low on T2C, ISO intense on T1 high on T2. Chapter 1. Test Paper 1, Questions. D. High on T1 high on T2. D. High on T1 high on T2. E. ISO intense on T1 ISO intense on T2. 22. An eccentric expansal lesion in the metaphysis of the humerus is noted incidentally following a routine plain radiograph investigation in a young patient following a rugby tackle. MRI performed for further characterization shows multiple cystic spaces, some with blood fluid level, with an intact low-signal periosteal rim. What is the diagnosis? Dannert W., Radiology Review Manual. 22. B. Aneurysmal bone cyst. Aneurysmal bone cysts, or ABCs, are most commonly seen between the first and third decades of life. They are typically a metaphyseal lesion, and are often located in the humerus, femur, or tibia. The presence of fluid levels along with bone expansion, a narrow zone of transition and metaphyseal location in a long bone is characteristic. Note that fluid levels can also be found in giant cell tumors, telangiectatic osteosarcomas and simple bone cysts, but the other associated locations and characteristics of the lesion would tend to be different from an ABC. Eosinophilic granulomas are associated with Langerhans cell histiocytosis. Enchondromas are typically located in the small long bones of the hands, and in the proximal humerus and femur with non-expansal characteristics. Fluid levels are not typically associated with fibrous dysplasia, which takes on the commonly described ground glass appearance. Monster BJ, ETAL musculoskeletal imaging, the requisites, 4th ed. Philadelphia. Diagnosis. A. D. Enchondroma. E. C. Eosinophilic granuloma. D. Enchondroma. E. Fibrous dysplasia. 23. A 34-year-old woman with previous history of upper limb weakness that resolved spontaneously and optic neuritis was referred for an MRI brain. MRI confirms the presence of bilateral periventricular hyperintensities on flare with abnormal signal in the corpus callosum and middle cerebellar peduncles. MRI also shows signal abnormality in the right optic nerve. Which portion of the optic nerve does multiple sclerosis, MS, most commonly affect? A. Intraorbital. Monster BJ, ETAL musculoskeletal imaging, the requisites, 4th ed. Philadelphia, PA, Mosby Elsevier, 2013:4950. 23. A. Intraorbital. Typically, findings of optic neuritis in MS are seen in the retrobulbar intraorbital segment of the optic nerve, which appears swollen, with high T2 signal. High T2 signal persists and may be permanent. Chronically the nerve will appear atrophied rather than swollen. Contrast enhancement of the nerve is best seen, with fat-suppressed T1, weighted coronal images, in 90% of patients if scanned within 20 days of visual loss. Coopersmith MJ, ETAL contrast-enhanced MRI in acute optic neuritis, relationship to visual performance. Brain. 2002, 125, for 8/12/22. 24. C. L2 to L3 the conus intraorbital. B. Intracanalicular. C. Intracranial. D. Chiasmatic. E. All portions are equally susceptible. Susceptible. 24. A newborn baby has US of the spine. At which level is the conus expected to be? A. Above L1B, above T1-2C, L2 to L3D, L3 to L4E, S2. 25. A middle-aged woman normally lies at or above the L2 disc space. A normal conus located at the mid-L3 level may be identified, especially in preterm infants. This position is considered the lower limits of normal but is usually without clinical consequence. However, in a preterm infant with a conus that terminates at the L3 midvertebral body, a follow-up sonogram can be obtained once the infant attains a corrected age between 40 weeks gestation and 6 months of age. In contrast, the thecal sac terminates at S2. In the preterm group, more than 90% of conus medullaris cases lie above L2. In the term group, more than 92% lie above L2. Kessler H. ETAL termination of the normal conus medullaris in children, a whole spine magnetic resonance imaging study. Neurosurg focus. 2007, 23, 2E7. Sahin F. ETAL level of conus medullaris in term and preterm neonates. Presence with cough and hemoptysis. Her chest X-ray reveals a large ovoid mass in the right lower lobe. She has a known history of Osler-Weber-Rondeau syndrome. What is the most appropriate next imaging investigation that you will organize? 26. A nursing home resident is found to have a lung tumor and undergoes CT staging of the chest and abdomen. Kessler H. ETAL termination of the normal conus medullaris in children, a whole spine magnetic resonance imaging study. Neurosurg focus. 2007, 23, 2E7. Sahin F. ETAL level of conus medullaris in term and preterm neonates. Arch disc child fetal neonatal ed. 1997, 77, 1F67 9. 25. C. CTPA with portal phase images covering the liver. Hereditary hemorrhagic telangiectasia, also called Osler-Weber-Rondeau syndrome, is an uncommon genetic disorder characterized by arteriovenous malformations in the skin, mucous membranes and visceral organs. The brain, gastrointestinal tract, skin, lung and nose are the primary sites affected. It is associated with the classic triad of epistaxis, telangiectasias, and a family history. Pulmonary AVMs are often discovered initially as a solitary pulmonary nodule or mass on plain chest films. If a pulmonary AVM is suspected, further imaging evaluation should be CT or conventional pulmonary angiography. Although conventional angiography is the gold standard, considering its invasive nature, CT is considered a better method of diagnosis. This is more important when screening for AVM. Portal venous phase liver images are often obtained at the same time, in case the lesion does turn out to be a solid nodule. Poole P.S., Ferguson E.C., Revisiting Pulmonary Arteriovenous Malformations, Radiographic and CT Imaging Findings and Corresponding Treatment Options. Contempt Dian Radiol. 2010, 33, 815. 26. Abdomen. This reveals a discrete lesion medial. Lesion medial to the second part of the duodenum with a fluid level. What is the most likely diagnosis? A. Duplication. 26. B. Duodenal diverticulum. Duodenal diverticulosis is a common entity first described by Chamel in 1710. Its prevalence varies depending on the mode of diagnosis. Diverticula are found in 6% of upper gastrointestinal series, 9%, 23% of ERCP procedures, and 22% of autopsies. Its occurrence has no sex predilection, and the age range for detection varies from 26 to 69 years. Duodenal diverticula may be congenital or acquired, with the latter being more common. Congenital or true diverticula are rare, contain all layers of the duodenal wall, and may be subdivided into intraluminal and extraluminal forms. The CT appearance of a duodenal diverticulum includes a saccular outpouching, which may resemble a mass-like structure interposed between the duodenum and the pancreas that contains air and air fluid level, fluid, contrast material, or debris. A periampullary diverticulum may simulate a pseudocyst or tumor. Pearl MS, ETAL CT findings in duodenal diverticulitis. AJR AMJ Rentgenol. 2006, 187, W3925. 27. C. Gartner's duct cyst postural. Duplication cyst B, duodenal diverticulum C, duodenal web D, annular pancreas E, adenocarcinoma of the duodenum. 27. Which of the following is false? A. Skene cyst lateral to external urethral meatus B, Nabothian cyst lateral to the endocervical canal. Chapter 1. C. Gartner's duct cyst posterolateral aspect of the upper vagina D, Bartholin's cyst posterolateral aspect of the vagina E. Urethral diverticulum posterolateral aspect of midurethra. Posterolateral aspect of the upper vagina. Multiple parurethral Skene's glands are related to the female urethra. There are parurethral ducts that drain into the distal urethral lumen. Nabothian cysts are retention cysts in the cervix related to chronic cervicitis. Gartner's duct cysts are found at the anterolateral aspect of the proximal third of the vaginal wall. Bartholin's gland cysts affect the posterolateral aspect of the lower vaginal wall. Urethral diverticulum occurs at the posterolateral aspect of the midurethra. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott, Williams and Wilkins, 2011:934, 1032, 1062. 28. C. Midurethra. 28. A 31-year-old man who is known to the gastroenterologist and rheumatologist presents to the ophthalmology department with visual disturbances. A pelvic radiograph done a year ago in the emergency department showed whiskering of the ischial tuberosities and greater trochonters, with symmetrical sclerosis of both sacroiliac joints. What is the most likely diagnosis? A. Reiter syndrome B. Besset syndrome C. Ankylosing spondylitis, as D. Rheumatoid arthritis E. Systemic lupus erythematosus. C. Ankylosing spondylitis, as is characterized by the hallmark of bilateral and symmetrical sacroiliac joint involvement, though there may be unilateral involvement in the early stages of disease. Other common findings include periostitis with whiskering of the pelvic bones and the typical bamboo spine appearance from syndesmophyte formation. Up to 10% of his cases are associated with inflammatory bowel disease, and iritis is common in up to 40% of patients. 96% of patients are HLA-B27 positive, the antigen associated with the other seronegative spondyloarthropathies of psoriasis, Reiter's syndrome, and inflammatory bowel disease-associated spondyloarthritis. Bessett's syndrome affects the chest and gastrointestinal tracts, and doesn't involve the skeleton primarily. Dannert W., Radiology Review Manual, 6th. Sixth N. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2007:46-7. Rudwellite M. Benton D. Ankylosing spondylitis and bowel disease. Best Pract Residential Clin Room et al. 2006, 23 for 5171. 29. Erythematosus, SLE. 29, a 36-year-old woman with resolving limb weakness and previous history of optic neuritis is diagnosed as having relapsing remitting multiple sclerosis, RRMS. Which of the following statements concerning MS imaging is incorrect? A. Black holes correlate well with clinical outcome. B. Brain atrophy is higher in MS than normal aging. C. The pattern of brain atrophy can mimic Alzheimer's disease. D. Diffusion tensor imaging demonstrates structural damage to the white matter. E. MS lesions have low MTR, magnetization transfer ratio, representing myelin loss. 30. A 3-year-old presents as acutely unwell with a maculopapular rash, lymphadenopathy, and erythema of her palms. 29. C. The pattern of brain atrophy can mimic Alzheimer's disease. The T1 lesion load including enhancing lesions, or black holes is correlated more closely than T2 lesion load with clinical outcome. Another imaging hallmark of MS is brain atrophy. Brain atrophy in MS usually appears as enlarged ventricles and reduced size of the corpus callosum. The rate of brain atrophy is higher in MS than in the normal aging process. Significant loss of white matter rather than gray matter is seen in the early stage of MS, suggesting a different mechanism of atrophy. Chapter 2. Test Paper 1, Answers. Compared to neurodegenerative diseases such as Alzheimer's disease, MS lesions show reduced magnetization transfer ratio, MTR, reflecting decreased myelin content. MTR is also reduced in normal-looking white matter, representing occult tissue damage. MS lesions usually have a more reduced MTR, as compared with ischemic lesions in small vessel diseases. Such occult tissue damage is also detected by diffusion tensor imaging, showing reduced fractional anisotropy, representing microstructural damage. GEY, multiple sclerosis, the role of MR imaging. AJNR AMJ Neuroradiol. 2006, 27, 611-65-76. 30. B. Kawasaki arteritis. Kawasaki disease is a systemic vasculitis that is palms. Her white cell count is normal, and a specific cause for her symptoms is not found. She improves on immunoglobulins and supportive treatment. A follow-up echocardiogram shows cardiomegaly and a coronary artery aneurysm. What is the likely diagnosis? A. Takayasu arteritis. B. Kawasaki arteritis. C. Moyamoya syndrome. D. Haynock-Schönlein purpura. E. Churg-Strauss syndrome. More severe in small and medium arteries and veins to a lesser extent, with inflammatory lesions in virtually all organs. It is a leading cause of acquired heart disease in childhood. The etiology of KD remains unknown, although the clinical presentation self-limiting illness manifested by an abrupt onset of fever, rash, exanthema, conjunctival injection and cervical adenopathy, and the epidemiological features a seasonal peak in winter and spring, age distribution, and a geographic wave-like spread of illness during epidemics strongly suggest an infectious cause. Fever is usually the first sign of KD. Rash is nonspecific and mostly maculopapular. Cervical lymphadenopathy is the last common of the main manifestations. Cardiovascular complications include coronary artery aneurysms, myocarditis, pericarditis with pericardial effusion, systemic arterial aneurysms, valvular disease, mild aortic root dilatation and myocardial infarct. Takayasu arteritis, TA, also known as pulseless disease, is a granulomatous large vessel vasculitis that predominantly affects the aorta and its major branches, with increased prevalence in Asian women 50 years of age. Churg-Strauss syndrome is a small to medium vessel necrotizing pulmonary vasculitis, affecting patients in the 3rd and 4th decades with asthma, eosinophilia, and systemic symptoms like purpura and arthralgia. Moyamoya disease is an idiopathic, non-inflammatory, non-atherosclerotic, progressive vasculo-occlusive disease involving the circle of Willis, typically the supraclinoid internal carotid arteries. It has a bimodal age distribution, affecting children and adults. In children, ischemic strokes are most pronounced, whereas in adults hemorrhage from the abnormal vessels is more common. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011. Duarte R., ETAL Kawasaki disease, a review with emphasis on cardiovascular 31. A 76-year-old male patient with chronic inflammatory disease and known history of secondary generalized multisystem amyloidosis showed an abnormal appearance of the heart on echocardiography. Dynamic enhanced cardiac MR imaging was advised for further characterization. All of the following are imaging findings seen with cardiac amyloidosis, except A. A. Left ventricular wall hypertrophy. B. Subendocardial delayed myocardial hyperenhancement. C. Systolic dysfunction. D. Granular echogenic myocardium. E. Interatrial septal thickening. Cardiovascular complications. Insights Imaging. 2010, 1 for 22331. 31. C. Systolic dysfunction in cardiac amyloidosis. The amyloid protein is deposited in the myocardium, which leads to diastolic dysfunction that progresses to restrictive cardiomyopathy. Because amyloidosis is a systemic process, involvement of all four chambers is common, thus, an increase in the thickness of the interatrial septum and right atrial free wall by more than 6 mm has been shown to be a specific finding for cardiac amyloidosis. Through the use of dynamic enhanced cardiac MRI, a distinct pattern of late enhancement, which was distributed over the entire subendocardial circumference, has been shown to have high specificity and sensitivity for cardiac amyloidosis. Echocardiogram shows concentric LV hypertrophy, with hyperechoic granular sparkling of the ventricular wall. Chun E.J., ETAL hypertrophic cardiomyopathy. Assessment with MR imaging and multi-detector CT. Radiographics. 2010, 35. 5. Thickening. 32. A taxi driver has had recurrent episodes of abdominal pain. On CT, a lesion is seen within the head of the pancreas. Pancreatic duct dilatation is noted with a normal CBD and atrophy of the body and tail of the pancreas. ERCP demonstrates thick mucous material discharging from the bulging papilla. What is the most likely diagnosis? Diagnosis. A. Mucinous cyst adenocarcinoma. B. Serous cyst adenocarcinoma. Chapter 1. Test Paper 1. Questions. 6. C. Main duct. IPMN. Intraductal papillary mucinous neoplasm. D. Pancreatic pseudocyst. E. Pancreatic adenocarcinoma. 33. A 55-year-old. 5/13/09/28. 32. C. Main duct IPMN. Intraductal papillary mucinous neoplasm. IPMNs are group of neoplasms in the biliary duct or pancreatic duct that causes cystic dilatation from excessive mucin production and accumulation. The true incidence of IPMNs is unknown because many are small and asymptomatic. However, in a series of 2,832 consecutive CT. Chapter 2. Test Paper. Scans of adults with no history of pancreatic lesions, 73 cases of pancreatic cysts, 2.6%, were identified. Many of these cases likely were IPMNs, given that IPMNs account for 20–50% of cystic pancreatic neoplasms. There are three main types of pancreatic IPMNs: main duct, branch duct, and combined. A main duct IPMN commonly causes dilatation of the papilla, with bulging of the papilla into the duodenal lumen. Filling defects caused by mural nodules or mucin may be seen at MRCP or ERCP. At CT and MRI, filling defects caused by mural nodules enhance, while filling defects caused by mucin do not enhance. Nicolaides P. ETAL imaging features of benign and malignant ampullary and periampullary lesions. Radiographics. 20. Man with several episodes of epididymoorchitis in the past has an ultrasound of the scrotum. The radiologist performing the scan notices several hypoechoic structures within the mediastinum testis and incidental epididymal cysts. There was no Doppler flow. What is the most likely diagnosis? A. 2014, 34:62441. 33. E. Cystic transformation of reedy testis. Cystic transformation of reedy testis is a benign condition, also known as tubular ectasia, resulting from partial or complete obliteration of the efferent ductules that causes ectasia and, eventually, cystic transformation. The location of the lesion in or adjacent to the mediastinum testis and the presence of epididymal cysts are characteristic. Cystic dysplasia of the reedy testis is a rare benign testicular tumor that is found mainly in the pediatric population. Abscesses are usually secondary to epididymoorchitis, however, they appear cystic with shaggy, irregular walls, intratesticular location, low-level internal echoes, and occasionally hypervascular margins. Teratomas are the most frequent to manifest as cystic masses, however, cystic tumors are rare and, when present, usually have an abnormal rind of parenchyma with increased echogenicity surrounding the cystic lesion. Dogra vs. ETAL benign intratesticular cystic lesions, U.S. features. Radiographics. 2001, 20. Lymphoma of the testes B, cystic dysplasia of the testis C, seminoma D, abscess E, cystic transformation of reedy testis. 34. An elderly woman presents with progressive atraumatic pain within her right knee over the course of the last month, particularly on the medial aspect, associated with functional impairment. Her clinical history includes a meniscal tear, which was treated arthroscopically 10 years ago with a good outcome. An MRI reveals florid marrow edema within the medial femoral condyle associated with mild flattening of the weight-bearing surface. What is the diagnosis? S21, S27381. 34. D. Spontaneous osteonecrosis of the knee. Spontaneous osteonecrosis of the knee, SONK, is a rapid and painful condition in elderly patients that ultimately results in subchondral collapse of the weight-bearing portion of the medial femoral condyle. It is often idiopathic but can be associated with minor trauma. It is now also increasingly recognized as a subchondral insufficiency fracture resulting in rapid secondary subchondral collapse. Perdas disease is a childhood disease with avascular necrosis of the femoral head. Sinding-Larsen disease is essentially tendinosis of the proximal origin of the patella tendon. Blunt's disease is a growth disorder of the tibia resulting in a bow leg deformity from disturbance to the medial proximal tibial epiphysis. An osteochondral defect is a traumatic injury involving the articular cartilage and adjacent subchondral bone. Diagnosis. A. Perdas disease B, Sinding-Larsen's disease C, Blunt's disease D, spontaneous osteonecrosis of the knee E, osteochondral defect. 35. A known MS patient has presented to the neurologist with clinical features of involvement of the spinal cord. An MRI of the whole spine has been requested with a view towards assessment of the cord for possible multiple sclerosis, MS, plagues. MS lesions in the spinal cord occur most commonly in the A. cervical segment, B. thoracic segment, C. lumbar segment, D. sacral segment, E. all segments are equally affected. 36. Monster BJ, ETAL musculoskeletal imaging, the requisites, 4th ed. Philadelphia, PA, Mosby Elsevier, 2013:21213. 35. A. Cervical segment MS can show multiple lesions in the spinal cord. Typical spinal cord lesions in MS are relatively small and peripherally located. They are most often found in the cervical cord, and are usually less than 2 vertebral segments in length. Bot JC, ETAL spinal cord abnormalities in recently diagnosed MS patients, added value of spinal MRI examination. Neurology. 2004, 62:22633. 36. C. A neonate presence with non-bilious vomiting with a palpable upper abdominal lump. Which of the following U.S. findings would not be in keeping with pyloric stenosis? A. Pyloric muscle. C. Pyloric canal length of 14 mm. Ultrasound is the modality of choice because of its advantages of directly visualizing the pyloric muscle and no ionicing radiation. The hypertrophied muscle is hypoechoic, and the central mucosa is hyperechoic. Normal measurements of the pylorus are as follows. Pyloric muscle thickness, i.e., the diameter of a single muscular wall on a transverse image, love mm, most accurate, length, i.e., longitudinal measurement 15-17 mm. Pyloric volume, 1.5 cm cubed. Pyloric transverse diameter, 13 mm. Abnormal features on US includes target sign, hypoechoic ring of hypertrophied pyloric muscle around echogenic mucosa centrally on cross-section, cervix sign, indentation of muscle mass on fluid-filled antrum on longitudinal section, and antral nipple sign, redundant pyloric channel mucosa protruding into gastric antrum. Other features include increased antral peristalsis and delayed gastric emptying. Infantile pyloric spasm also shows increased peristalsis and delayed gastric emptying with pyloric muscle thickness between 1.5 and 3 mm. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011. 37. C. Infundibular stenosis. Tetralogy. Muscle thickness 3.5 mm. B. Target sign C. Pyloric canal length 14 mm. D. Antral nipple sign E. Cervix sign. 37. A child with exertional dyspnea, an abnormal chest X-ray showing a boot-shaped heart, and oligamic lungs is diagnosed as suffering from tetralogy of Fallot. The pulmonary oligamia, old man presents with recurrent episodes of abdominal pain. Blood amylase is normal. Chronic pancreatitis is suspected. All of the following statements regarding MRI imaging in chronic pancreatitis are true, except A. MRI has a poor sensitivity for detecting parenchymal calcification in chronic pancreatitis. B. MRI allows evaluation of the ductal system for strictures and stones, debris within pseudocysts and fistula. C. MRI shows good sensitivity for the differential diagnosis of focal chronic pancreatitis from pancreatic carcinoma. D. Both focal chronic pancreatitis and pancreatic carcinoma demonstrate abnormal post-contrast enhancement on MRI. E. Both focal chronic pancreatitis and pancreatic carcinoma demonstrate low signal intensity of the pancreas on T1W fat-saturated images. 39. A 60-year-old heavy Radiol. 2009, 32, 1216. 38. C. MRI shows good sensitivity for the differential diagnosis of focal chronic pancreatitis from pancreatic carcinoma. The diagnosis of chronic pancreatitis on MRI is based on signal intensity and enhancement changes as well as on morphologic abnormalities in the pancreatic parenchyma, pancreatic duct and biliary tract. The imaging features of chronic pancreatitis can be divided into early and late findings. Early findings include low signal intensity pancreas on T1, weighted fat-suppressed images, decreased and delayed enhancement after for contrast administration, and dilated side branches. Late findings include parenchymal atrophy or enlargement, pseudocysts, and dilatation and beating of the pancreatic duct, often with intraductal calcifications. Differentiating between an inflammatory mass due to chronic pancreatitis and pancreatic carcinoma on the basis of imaging criteria remains difficult. Decreased T1 signal intensity with delayed enhancement after gadolinium administration, as well as dilatation and obstruction of the pancreaticobiliary ducts can be seen in both diseases. Irregularity of the pancreatic duct, intraductal or parenchymal calcifications, diffuse pancreatic involvement, and normal or smoothly stenotic pancreatic duct penetrating through the mass duct penetrating sign favor the diagnosis of chronic pancreatitis over cancer. In distinction, a smoothly dilated pancreatic duct with an abrupt interruption, dilatation of both biliary and pancreatic ducts, double duct sign, and obliteration of the perivascular fat planes favor the diagnosis of cancer. Miller F.H., ETAL MRI of pancreatitis and its complications, Part 2, Chronic Pancreatitis. AJR AMJ Rentgenol. 2004. Heavy smoker presence with hematuria. USKUB shows a midline fluid-filled cavity with mixed echogenicity and calcification adjacent to the bladder wall. CT shows a focal low attenuation enhancing mass along a cord-like structure extending from the bladder to the umbilicus. What is the most likely diagnosis? – 2004, 183:1645-1652. 39. C. Urachal adenocarcinoma. Urachal adenocarcinoma is characteristically located at the dome of the bladder in the midline or slightly off midline. 90% of masses occur close to the bladder, with the remainder along the course of the urachus or at the umbilical end. A midline, infraumbilical, soft tissue mass with calcification is characteristic and is considered to be urachal adenocarcinoma until proved otherwise. 80% of urachal cancers are adenocarcinoma. At CT, the tumor is mixed solid. Chapter 2. Test Paper 1, Answers. And cystic in 84% of cases and solid in the remainder. CT is the most sensitive modality for calcification, which is present in 72% of cases, and is more commonly peripheral than stippled. On T2, weighted MRI, focal areas of high signal intensity from mucin are highly suggestive of urachal adenocarcinoma. The solid portions of the tumor are iso-intense to soft tissue on T1, weighted images, and enhanced with intravenous contrast material. Wang Yuchong J.J., ETAL. From the archives of the AFIP, neoplasms of the urinary bladder, radiologic pathologic. Focal low attenuation enhancing mass along a cord-like structure extending from the bladder to the umbilicus. What is the most likely diagnosis? A. Complex urachal cyst. B. Vesico-urachal diverticulum. C. Urachal adenocarcinoma. D. Transitional cell carcinoma. E. Urachal rhabdomyosarcoma. 40. A 10 times 7 mm dense ossified focal lesion is noted in the neck of the right femur of a young man incidentally on a pelvic radiograph performed for an unrelated reason. The lesion has benign features and is consistent with a bone island, enostoses. No follow-up is suggested. All of the following are true of bone islands except A. If more than 2 cm, they are classified as a giant bone island. B. They have a sclerotic appearance on imaging. C. They show a characteristic brush border on plain films. D. They can be positive on a bone scan. E. Giant bone islands can be locally aggressive. 41. A patient recently diagnosed with MS has been sent for an MRI of the whole spine to detect possible spinal radiologic pathologic correlation. Radiographics. 2006, 26, 25 53 80. 40. E. Giant bone islands can be locally aggressive. Bone islands are benign entities and represent compact bone within the medullary space. They do not exhibit aggressive features regardless of size. Classically, they are sharply defined with thorny radiations, brush border. Then can occasionally show increase or decrease in size, about a third of them, cf. Osteoblastic metastasis, which shows aggressive features, cortical break/destruction, periosteal reaction or soft tissue component. Osteoid osteoma is associated with typical pain and anitis. Dannert W., Radiology Review Manual, 6th ed. Philadelphia, PA. Spinal plagues. All of the following are Mr. features of spinal cord lesions in MS, except A. The sole site of involvement in some cases. B. Imaging features similar to those of MS lesions in the brain. C. Most lesions are centrally located. D. The length rarely exceeds 2 vertebral segments. E. Dorsal column involvement. PA, Lippincott Williams and Wilkins, 2007:50. 54. 41. C. Most lesions are centrally located. Occurrence of spinal cord abnormalities is largely independent of brain lesions in MS. Both focal and diffuse lesions affecting the cord are described, though multiple focal lesion, median 3, is the most common finding. Patients with focally involved spinal cords mostly show multiple small lesions. Focal lesions have an elongated configuration along the axis of the spinal cord and affect the peripheral part of the cord. Cervical cord is the most commonly affected segment, and the lesions usually extend over fewer than 2 vertebral segments in length. Bott J.C., ETAL spinal cord abnormalities in recently diagnosed MS patients, added value of spinal. 42. Barium enema of a neonate. Neonate shows an inverted cone shape at the rectosigmoid colon. There is marked retention of the barium on delayed post-evacuation films after 24 hours. The cause for this is A. Meconium ileus. B. Meconium plug syndrome. C. Hirschsprung's disease. D. Imperforate anus. E. Hyperplastic polyp of colon. Chapter 1. Test Paper 1, Question. Spinal MRI Examination. Neurology. 2004, 62, 2226 33. 42. C. Hirschsprung's disease. Hirschsprung's disease, also called aganglionosis of the colon, absence of parasympathetic ganglia in muscle and submucosal layers secondary to an arrest of craniocaudal migration of neuroblasts, results in relaxation failure of the aganglionic segment. It affects full-term infants during the first weeks of life, mainly boys. It is extremely rare in premature infants. It usually affects the rectosigmoid junction and results in short segment disease, 80%. Long segment disease, 20%, and total colonic aganglionosis, 5%, are less common. Barium enema shows a transition zone, aganglionic segment, which appears normal in size with dilatation of large and small bowel proximally with marked retention of barium on delayed films after 24 hours. Normal children show a rectosigmoid ratio of greater than 1, as the rectum is larger in diameter than the sigmoid. In the case of Hirschsprung's disease, the ratio is reversed, rectosigmoid ratio, 1. Dannert W., radio. A 3-year-old child with shortness of breath is diagnosed with tetralogy of Fallot. All of the following abnormalities may be associated with this condition, except A. Transposition of great vessels, TGA, B. Patent ductus arteriosus, PDA, C. Anomalous origin of coronary arteries, D. DeGeorge syndrome, E. Right-sided aortic arch. Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011. 43A. Transposition of great vessels, TGA. A number of associated features can occur in patients with tetralogy of Fallot, TOF. Right-sided aortic arch is the most common variant, known as Corvisart syndrome. Coronary artery anomalies, such as the left anterior descending artery arising from the right coronary artery, whose course may run directly across the right ventricular outflow tract, can occur. Other associations include patent ductus arteriosus, multiple ventricular septal defects, and complete atrioventricular septal defect. Approximately 15% of patients have extracardiac anomalies, including chromosomal abnormalities such as Down syndrome, DeGeorge syndrome, and Alagille syndrome. Chang E.Y., Stark P., Imaging of Tetralogy of Fallot, a continuum from infancy to adulthood. Contempt Diane Radiol. 2000. 44, a 40-year-old woman presents to her GP with right upper quadrant pain and is referred for an ultrasound of the abdomen. The scan demonstrates a thickened gallbladder wall with several intramural small echogenic foci showing comet tail artifacts. A few gallstones are also noted. What is the most common diagnosis? D. Gallbladder adenomyomatosis. Adenomyomatosis is a benign hyperplastic cholecystosis. It is a relatively common condition, identified in at least 5% of cholecystectomy specimens. There is no definite racial or sex predilection. Most diagnoses are made in patients in their 50s, but the age range is wide in case reports exist of pediatric adenomyomatosis. Adenomyomatosis is most often an incidental finding, has no intrinsic malignant potential, and usually requires no specific treatment. It frequently coexists with cholelithiasis, but no causative relationship has been proved. Adenomyomatosis occasionally produces abdominal pain, and in some cases cholecystectomy may be indicated for relief of symptoms. Cholesterol accumulation in adenomyomatosis is intraluminal, as cholesterol crystals precipitate in the bile trapped in Rokitansky-Askoff sinuses, intramural diverticula lined by mucosal epithelium. Gallbladder wall thickening and intramural diverticula containing bile with cholesterol crystals, sludge, or calculi are the pathologic correlates of the distinctive multimodality imaging features of adenomyomatosis. US is a primary modality for biliary imaging, and adenomyomatosis of the gallbladder is frequently identified at sonography. The nonspecific finding of gallbladder wall thickening is well demonstrated with US, as are sludge and calculi when present. Echogenic intramural foci from which emanate V-shaped comet tail reverberation artifacts are highly specific for adenomyomatosis, representing the unique acoustic signature of cholesterol crystals within the lumina of Rokitansky-Askoff sinuses. Sinuses. Boskake AR, ETAL best cases from AFIP. Adenomyomatosis. Diagnosis. A. Xanthogranulomatous cholecystitis. B. Strawberry gallbladder. C. Porcelain gallbladder. D. Gallbladder adenomyomatosis. E. Acute cholecystitis. 45. A woman presents with infertility and undergoes a hysterosalpingogram. This demonstrates a uterus with two converging horns. A wide angle is seen at the roof of the uterus. Uterus. Which uterine anomaly does the patient have? A. Uterine didelphys. B. Septate uterus. C. Arcuate uterus. D. Bicornuate uterus. E. Unicornuate. Adenomyomatosis, representing the unique acoustic signature of cholesterol crystals within the lumina of Rokitansky-Askov sinuses. Boskake AR, ETAL best cases from AFIP. Adenomyomatosis of the gallbladder. Radiographics. 2006, 26:941-6. Published online. 45, D. Bicornuate uterus. While the presence of a divided rather than triangular uterine cavity at hysterosalpingogram, HSG, may suggest the presence of an Mullerian duct anomaly, MDA, it is not possible to differentiate between subtypes. MRI and US provide greater anatomic detail. Both of these imaging methods provide information on the external uterine contour, which is an important diagnostic feature of MDAs. Furthermore, both MRI and US may be used to assess for concomitant renal anomalies. Renal anomalies occur at a higher rate among MDA patients. Unicornuate uterus appears as a small, oblong, off-midline structure on US and MRI. Uterus didelphys results from complete failure of Mullerian duct fusion. Each duct develops fully with duplication of the uterine horns, cervix and proximal vagina. A fundal cleft greater than 1 cm has been reported to be 100% sensitive and specific in differentiation of fusion anomalies, didelphys and bicornuate, from reabsorption. Anomalies, septate and arcuate. Bicornuate uterus involves duplication of the uterus with possible duplication of the cervix, bicornuate unicalis or bicornuate bicalis. HSG demonstrates opacification of two symmetric fusiform uterine cavities, horns, and fallopian tubes. Historically, an intercornual angle of greater than 105 degrees was used for diagnosis of bicornuate uterus. Septate uterus is the most common form of MDA, accounting for approximately 55% of cases. Historically, an angle of less than 75 degrees between the uterine horns has been reported to be suggestive of a septate rather than bicornuate uterus. However, considerable overlap occurs between septate and bicornuate uteri. As such, the angle measurement is not a reliable diagnostic feature. Arcuate uterus at HSG shows a single uterine cavity with a broad saddle-shaped indentation at the uterine fundus. Bare SC, ETAL imaging of Mullerian. Unicornuate uterus. 46, a 53-year-old woman presents to the A&E department with acute knee pain. She has had 2 previous similar episodes in the past, which settled with analgesics and anti-inflammatory medications. Plain films show extensive degenerative change, which is worst at the patellofemoral joint with large subchondral cystic change and chondrocalcinosis of the knee menisci. She informs the attending doctor that she is under review with the endocrinologist. What is the likely diagnosis? A. Calcium pyrophosphate deposition disease, CPPD, B. Gout C. Rheumatoid arthritis D. Ochronosis E. Psoriasis. 40. Mullerian duct anomalies. Radiographics. 2012, 32, 6E2 3350. 46. A. Calcium pyrophosphate deposition disease, CPPD. This is a typical description of CPPD, which can be idiopathic or associated with endocrinological problems such as hyperparathyroidism and hypothyroidism. The joints of the knee, wrist and 2nd/3rd MCP joints of the hand are most frequently involved. Differentials would also include gout, but the distribution of erosions are different, with gouty erosions tending to be juxtaarticular and punched out, rat-bitten, rather than subchondral. Joint space is also typically preserved in gout until the late stages. Psoriasis produces enthesitis and periostitis. Chapter 2. Test Paper 1, Answers. 38. With new bone formation. Ochronosis, or alkaptonuria, is a metabolic disorder whereby there is abnormal buildup of homogentisic acid in connective tissue with pigmentation of the sclera, and urine appearing dark in color. Diffuse multilevel vertebral disc calcification and early OA changes in multiple joints are associated with this condition. Monster BJ, ETAL muscular. 47, a 54-year-old man who developed brain metastases, almost 9 years after resection of an acrolentiginous melanoma of the distal thumb shows 2 peripheral nodules in the right frontal lobe. All of the following are features of CNS metastatic melanoma, except A, moderate to intense enhancement post-contrast administration B, cystic components C, subependymal nodules D, multiple lesions at the gray-white matter junction E, miliary pattern. Musculoskeletal imaging, the requisites, 4th ed. Philadelphia, PA, Mosby Elsevier, 2013:2989. 47, B, cystic components metastatic malignant melanoma, is a commonly encountered neoplasm in the head. Typical appearance of a lesion is high signal intensity on T1, weighted images, and low signal on T2, weighted images, melanotic pattern. The other described pattern is the amylanotic pattern. In this pattern, the lesion is hypointense or isointense to the cortex on T1, weighted images, and hyperintense or isointense to the cortex on T2, weighted images. Metastatic melanoma presences multiple brain metastases, which are located predominantly in the cortex and at the gray matter-white matter junction. They can also present in miliary form or as subependymal nodules. The lesions often appear hyperdense on unenhanced CT. The lesions show moderate to intense contrast enhancement, although larger lesions can show non-enhancing or hyper Hypoenhancing necrotic areas. Prominent perilesional edema is seen. Scene. Escott E.J. Pattern. 48. A child presents with vomiting and sudden onset. Abdominal pain. Plain X-rays show a target sign in the right upper quadrant. US shows a pseudo-kidney sign in keeping with intussusception. Intussusception. Which of the following is false regarding hydrostatic reduction? A. Free intraperitoneal air is a contraindication. B. A maximum of 2 attempts can be made. Chapter 1. Test Paper 1, Questions. C. Air is preferred to gastrograph in water solution in some institutions. D. The perforation rate is 0.4% 3%. E. Air enema is associated with a higher perforation rate. 49. Plain X-ray. Especially if greater than 48 hours, passage of blood via the rectum, significant dehydration. Dehydration, small bowel obstruction and visualization. OA changes in multiple joints are associated with and urine appearing dark in color. Lesions often appear hyperdense on unenhanced CT. The lesions show moderate to intense contrast enhancement, although larger lesions can show non-enhancing or hypoenhancing necrotic areas. Prominent perilesional edema is seen. Escott E.J. A variety of appearances of malignant melanoma in the head, a review. Radiographics. 2001, 21, 362539. 48. B. Maximum of 2 attempts can be made. Intussusception is one of the most common causes of acute abdomen in infancy. Perforation may already have occurred before enema therapy, or may occur during the reduction process. There is no agreement on the number and duration of reduction attempts, the efficacy of premedication or sedation, the use of rectal tubes with inflatable retention balloons, or the use of transabdominal manipulation. The classic rule of threes is that the number of reduction attempts is capped at 3, lasting 3 minutes each. This rule has been discarded at some institutions, and some authors use a nearly unlimited number of attempts. Use of sedation, rectal tube with balloons, and the Valsalva maneuver are said to improve the reduction rate achieved. Absolute contraindications to enema therapy are shock not readily corrected with forehydration and perforation with peritonitis. Criteria that are linked to a lower reduction rate and a higher perforation rate are age less than 3 months or greater than 5 years, long duration of symptoms, especially if greater than 48 hours, passage of blood via the rectum, significant dehydration, small bowel obstruction and visualization of the dissection sign during enema therapy. Air enema produces excellent results, but is also associated with maximum perforation rates. Del Pozo. X-ray of a newborn shows a large tubular air shadow behind the trachea. The lungs are clear. The bowels are grossly distended with air. What is the likely type of tracheoesophageal fistula? A. Type AB, Type BC, Type CD, Type type D, type E. 50. Small bowel obstruction and visualization of the dissection sign during enema therapy. Air enema produces excellent results, but is also associated with maximum perforation rates. Del Pozo G, ETAL intussusception in children, current concepts in diagnosis and enema reduction. Radiographics. 1999, 19, 2299 319. 49. C. Type C. Different types of esophageal atresia are identified on the basis of the presence and location or absence of a tracheoesophageal fistula. Type A is pure esophageal atresia without fistula, and Type B is esophageal atresia with a fistula between the proximal pouch and the trachea. Type C is esophageal atresia with a fistula from the trachea, or the main bronchus to the distal esophageal segment. Type D is esophageal atresia with both proximal and distal fistulas, and Type E is an H-shaped tracheoesophageal fistula without atresia. Of these 5 types, Type C is by far the most common. Esophageal atresia is generally suspected on the basis of polyhydramnios, inability to swallow saliva or milk, aspiration during early feedings, or failure to successfully pass a catheter into the stomach. Feeding difficulties with choking occur in infants with Type E fistula without atresia, but the Chapter 2. Test paper. Diagnosis may not be made until several years later when the patient presents with a cough while swallowing, recurrent pneumonia, and a distended abdomen. In types A and B, there is a complete absence of gas in the stomach and intestinal tract, whereas in type C and D the gastrointestinal tract commonly appears distended with air. Barachal T, ETAL congenital anomalies of the upper gastrointestinal tract. Radiographics. 1999. 50. A 46-year-old American man who has come to the UK on a holiday trip arrives at the AED with worsening shortness of breath. Chest X-ray shows bilateral asymmetrical calcified mediastinal and hilar nodes, and chronic pulmonary histoplasmosis is provisionally diagnosed. The worsening symptoms are attributed to fibrosing mediastinitis. All the following conditions can occur as complications of fibrosing mediastinitis, except A, SVC syndrome, B, pulmonary arterial. Barachal T, ETAL congenital anomalies of the upper gastrointestinal tract. Radiographics. 1999, 19, for 855-72. 50. E. Aortic stenosis. Chronic histoplasmosis may lead to 2 well-described complications, fibrosing mediastinitis and bronchiolithiasis. Fibrosing mediastinitis is a fibrotic immune response to histoplasma antigens. The abnormal fibrosing process encases and narrows vital mediastinal structures, which can lead to superior vena cava syndrome, precapillary pulmonary arterial hypertension from pulmonary arterial stenosis, postcapillary pulmonary arterial hypertension owing to pulmonary vein stenosis, atelectasis from bronchial obstruction, tracheal stenosis, or dysphagia from esophageal obstruction. The imaging appearance can mimic infiltrating metastatic disease or lymphoma. However, the presence of mediastinal calcifications often provides a clue to the diagnosis. Bronchiolithiasis results from erosion of a calcified hilar lymph node into an adjacent bronchus. Affected patients present with chronic cough and hemoptysis, and even occasionally with lithoptysis. Typical imaging features include endobronchial calcification with atelectasis of the associated pulmonary segment or lobe. Arterial hypertension C, pulmonary venous stenosis D, tracheal stenosis E, aortic stenosis. 51. A 70-year-old pensioner has been referred for an abdominal ultrasound as part of a routine medical examination. He is fit and well with no significant past medical history. The skin demonstrates a small focal well-defined hyperechoic area in the right lobe of the liver showing posterior acoustic enhancement. The most likely differential diagnosis is A, metastasis, B, fatty infiltration, C, liver cyst, D, FNH, focal nodular hyperplasia, E, capillary hemangioma. McAdams HP, ETAL thoracic mycoses from endemic fungi, radiologic pathologic correlation. Radiographics. 1995, 15:255-70. SIC et RR, ETAL intrathoracic fungal diseases, a guide to classification and pictorial review part I, endemic fungi. Contempt Dian Radiol. 2009, 32-117. 51. E. Capillary hemangioma. The classic hemangioma is an asymptomatic lesion that is discovered at routine examination or autopsy. At US, the typical appearance is a homogeneous, hyperechoic mass with well-defined margins and posterior acoustic enhancement. The CT findings consist of a hypoattenuating lesion on non-enhanced images. After intravenous administration of contrast material, arterial phase CT shows early, peripheral, globular enhancement of the lesion. The attenuation of the peripheral nodules is equal to that of the adjacent aorta. Venous phase CT shows centripetal enhancement that progresses to uniform filling. This enhancement persists on delayed phase images. At MRI, hemangiomas are characterized by well-defined margins and high signal intensity on T2, weighted images, which is identical to that of cerebrospinal fluid. Specificity is improved by using serial gadolinium-enhanced gradient echo imaging. The gadolinium intake is similar to the intake of iodinated contrast material during enhanced CT. With T2, weighted spin echo and dynamic gadolinium-enhanced T1, weighted gradient echo sequences, the sensitivity and specificity of MRI are 98% and the accuracy is 99%. The imaging features of a hemangioma depend on its size. Typical hemangiomas are mostly less than 3 cm in diameter. Vilgrain v. ETAL imaging of atypical hemangiomas of the liver with pathologic correlation. Radiographics. 2000, 20:37997. Hemangioma. 52. The causes of medullary nephrocalcinosis include all, except A. Hyperparathyroidism B. Renal tubular acidosis C. Medullary sponge kidney D. Hypervitaminosis D. E. Alport syndrome. (97) 52. E. Alport syndrome causes of medullary nephrocalcinosis include hyperparathyroidism, sarcoidosis, myelomatoses, primary or secondary hyperoxaluria, Crohn's disease, hyperthyroidism, osteoporosis, idiopathic hypercalciuria, renal tubular acidosis, medullary sponge kidney and drug-induced hypervitaminosis D, milk alkali syndrome. Chapter 2. Alport syndrome is an autosomal dominant condition also called chronic hereditary nephritis, associated with ocular abnormalities, deafness, small kidneys, cortical calcification and progressive renal failure without hypertension. Adam A. ETAL Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:882. 53. A 56-year-old woman known to the endocrinologist has been going to her family doctor with a funny sensation in her right hand and fingers for the last few months. An MRI was organized along with nerve conduction studies by her family doctor. MRI revealed fusiform swelling of the median nerve in the distal forearm, just before the entrance into the carpal tunnel with increased signal on T2. What is the likely diagnosis? (53) C. Carpal tunnel syndrome. Imaging of carpal tunnel syndrome is controversial and diagnosis is primarily made on clinical grounds and nerve conduction studies. However, there are some imaging findings that can be associated with the syndrome. These include the pseudoneuroma, appearance of the median nerve, swelling of the median nerve just before the carpal tunnel entrance, increased T2 signal changes, and increased post-contrast enhancement. It is associated with acromegaly. Neurofibroma of the median nerve can account for the symptoms, but would tend to be more distinct as a lesion and sometimes associated with a low-signal central region. Dannert W., Radiology Review Manual, 6th ed. Philadelphia. (54) A 7-year-old boy with a history of a penetrating injury from a tree branch was sent for CT orbits for further assessment. Which of the following statements regarding the CT detection of intraorbital foreign bodies is false? A. Size, type and location of glass foreign body, FB, affix detection. B. Wooden FB is hyperattenuating. C. Old wood can be mistaken for air. D. Attenuation of wood changes with water content. E. CT can demonstrate metal FB less than a millimeter. Neurofibroma of the median nerve can account for the symptoms, but would tend to be more distinct as a lesion and sometimes associated with a low-signal central region. Dannert W., Radiology Review Manual, 6th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2007:56. Lucetti R., Amadio P., Carpal tunnel syndrome. New York, Springer, 2007:76. 54, B. Wooden FB is hyperattenuating. CT is a very sensitive imaging modality that can demonstrate metal fragments less than 1 mm in size. Non-metallic foreign bodies are more problematic, not only the size of the glass fragment, but also the type of glass and its location affect detection rates. Wooden foreign bodies usually appear hypoattenuating on CT images. Because of their low attenuation, they can be mistaken for air. If the low attenuation collection on CT displays a geometric margin, wood or organic FB should be suspected. The attenuation of wood changes over time as the water content changes, older wood being drier than fresh green wood. Cubble W.S. Imaging of orbital trauma. Radiographics. 2008, 28, 6/17/29. 55, a 56-year-old woman with an increase in shortness of breath comes to the A&E department and is assessed by the physicians. The ECG is low in voltage and a chest X-ray is organized. The chest X-ray shows a very large heart with sharply defined borders and a narrow pedicle, suggesting pericardial effusion. All of the following are associated, except A, tuberculosis pericarditis, B, blunt trauma to the sternum, C, hyperthyroidism, D, radiation pericarditis, E, pericardial lymphoma. (17 29 39). 55, C, hyperthyroidism, inflammation of the pericardium. Pericarditis, occurs in response to a variety of stimuli. It results in cellular proliferation or the production of fluid, pericardial effusion, either alone or in combination. Causes include myocardial infarction, acute or post-myocardial infarction, Dressler syndrome, pericardiotomy, mediastinal irradiation, infection, viral or bacterial, connective tissue disease, rheumatoid arthritis, SLE, metabolic disorders, uremia, hypothyroidism rather than hyperthyroidism, pericardial neoplasia, trauma and AIDS. Chest X-ray shows increased cardiac size, flask or water bottle configuration, filling of retrosternal space, effacement of cardiac borders and thickening of anterior pericardial stripe. Echocardiography is the investigation of choice for diagnosis. Adam A. E.T. E.T.A.L. Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:263. 56, E. Suspected hemangioma, contraindications for liver biopsy. Lymphoma. 56, a 66-year-old joiner presents to his GP with jaundice and abdominal discomfort. He was subsequently referred to a gastroenterologist who requests a liver biopsy due to deranged liver function tests. Which of the following options is not a contraindication for percutaneous liver biopsy? A. INR above 1.6, B. Platelets less than 60,000/mm3, 10 ascites, D. Extrahepatic biliary obstruction, E. Suspected hemangioma. Liver biopsy include the following. 1. Uncooperative patient. 2. Extrahepatic biliary duct dilatation, except if benefit outweighs the risk. 3. Bacterial cholangitis, relative contraindication due to risk of septic shock. 4. Abnormal coagulation indices. Having a normal INR or PT is not a reassurance that the patient will not bleed. However, there is increased incidence of bleeding with INR above 1.5. 5. Thrombocytopenia, platelet count below 60,000/mm3. 6. Presence of ascites. 7. Cystic lesion. Guidelines on the use of liver biopsy in clinical practice. Hemangioma. 57, a 40-year-old man who is a known hypothyroid patient, presents with weight loss and dull pain in the flank and back. He undergoes an abdominal CT. Regarding retroperitoneal fibrosis, all of the following is seen on imaging, except A. Medial deviation of the ureters in the middle third, typically bilateral. B. CT shows soft tissue mass displacing the aorta anteriorly. C. T2W MRI shows variable signal. D. PET CT has high sensitivity. E. Hydronephrosis is evident on CT urography. Practice. BSG Guidelines in Gastroenterology. 2004, available at www.bsg.org.uk/pdf_word_docs/liver_biopsy.pdf. 57, B. CT shows soft tissue mass displacing the aorta anteriorly. Intravenous urography usually demonstrates the classic triad of medial deviation of the middle third of the ureters, tapering of the lumen of one or both ureters in the lower lumbar spine or upper sacral region, and proximal unilateral or bilateral hydroureteronephrosis with delayed excretion of contrast material. CT and MRI is the mainstay of non-invasive diagnosis of retroperitoneal fibrosis, RPF. CT allows comprehensive evaluation of the morphology, location, and extent of RPF, and involvement of adjacent organs and vascular structures. Moreover, abdominal CT allows detection of diseases often associated with idiopathic RPF, e.g., autoimmune pancreatitis, or demonstrating an underlying cause in cases of secondary RPF, e.g., malignancy. CT shows a well-defined mass, usually anterior and lateral to the aorta, sparing the posterior aspect, and not causing aortic displacement. Idiopathic RPF typically has low signal intensity on T1 weighted images. The signal intensity on T2 weighted images is variable and reflects the degree of associated active inflammation, hypercellularity, and edema. After administration of contrast material, early soft tissue enhancement mirrors the degree of inflammatory activity observed at T2 weighted imaging. The sensitivity of 18F FDG PET is very high, which allows detection and quantification of the metabolic activity of retroperitoneal lesions. Although sensitivity is high, specificity is low, and aortic wall in the elderly can show FDG uptake. CAIFA RO, ETAL retroperitoneal fibrosis, role of imaging in diagnosis and follow-up. Radiographics. 2000. Urogram. 58, a 17-year-old teenager is under investigation for vague pain in the knee associated with a limp. A plain film radiograph shows an oval lucent lesion in the epiphysis of the distal femur. The pain was noticed following an injury sustained during a football match. What would be the next investigation of choice? A. CTB, MRI C, bone biopsy D, TC, 99M bone scan E. No imaging necessary since it looks benign. Quantification of the metabolic activity of retroperitoneal lesions. Although sensitivity is high, specificity is low, and aortic wall in the elderly can show FDG uptake. CAIFA RO, ETAL retroperitoneal fibrosis, role of imaging in diagnosis and follow-up. Radiographics. 2013, 33, 25, 35, 52. 58, B, MRI. A main differential for a symptomatic lesion in the epiphysis of a long bone in an unfused skeleton is a chondroblastoma. MRI will reveal the presence of marked reactive surrounding marrow edema. In a fused skeleton, the differentials would include clear cell chondrosarcoma, giant cell tumors, and other benign causes like subarticular cyst and interosseous ganglion. Chondroblastomas are very well defined with sclerotic margin on plain X-ray and low signal rim on MRI, cf. Langerhans cell histiocytosis, which appears less well defined with variable margins. Often definitive diagnosis requires surgical biopsy. Dannert W., Radiology. Radiology Review Manual, 6th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2007:50. Benign. 59. Abnormal high density is noted in the vitreous on CT orbits, suggesting the presence of blood in the posterior chamber. All of the following conditions are potential causes of vitreous hemorrhage, except A. Intraocular tumor, B. Abnormal vascularization of the retina, C. Terson syndrome. Terson syndrome. D. Corneal abrasion, E. Trauma. 60. A 1 month old. 56. 59. D. Corneal abrasion. Vitreous hemorrhage is common, with varied clinical manifestations and causes. The most common causes include proliferative diabetic retinopathy, vitreous detachment with or without retinal breaks, and trauma. Less common causes include vascular occlusive disease, retinal arterial macroaneurysm, hemoglobinopathies, age-related macular degeneration, intraocular tumors, and others. Terson syndrome is the occurrence of a vitreous hemorrhage of the human eye in association with subarachnoid hemorrhage. Goff M.J., ETAL. Causes and treatment of vitreous hemorrhage. Compare Ophthalmol Update. 2006, 7, 397, 111. 1 month old baby presents with difficulty in feeding and shortness of breath. Chest X-ray shows cardiomegaly. She has an episode of seizure and undergoes cranial US, which shows a median tubular cystic space with high-velocity turbulent flow on Doppler. The ventricles are also mildly dilated. These findings are consistent with A. Pineal tumor, B. Arachnoid cyst, C. Colloid cyst, D. Vein of Galen aneurysm, E. Ventriculitis. 111. 60. D. Vein of Galen aneurysm. Vein of Galen aneurysmal malformations, VGAMs, are rare congenital vascular malformations characterized by shunting of arterial flow into an enlarged cerebral vein dorsal to the tectum. Most of these malformations present in early childhood, often causing congestive heart failure in the neonate. Antenatal ultrasound scans demonstrate the venous sac as a sonolucent mass located posterior to the third ventricle. Ultrasonic demonstration of pulsatile flow within it helps in differentiating. Chapter 2. Test Paper 1, Answers. 42. VOGMs from other midline cystic lesions. Associated venous anomalies can often be visualized. Evidence of hydrocephalus and cardiac dysfunction can also be obtained on antenatal ultrasonography. Contrast-enhanced axial CT scan of the brain usually demonstrates a well-defined, multilobulated, intensely enhancing lesion located within the cistern of velum interpositum. Dilatation of the ventricular system and periventricular white matter hypodensities, as well as diffuse cerebral atrophy, are the commonly associated findings. Devel L. ETAL MRI imaging of vein of Galen malformations at Steve Biko Academic Hospital, a mini-case series. SAJ Radiol. 2011. Ventriculitis. 61, a 66-year-old man with progressive shortness of breath and low-volume ECG shows an enlarged heart on chest X-ray. Echocardiogram confirms the presence of a moderately large pericardial effusion. The pericardial fluid is aspirated for symptomatic relief and sent off for cytology and culture. Cytology comes back as positive for malignant cells. Which of the following is the most common type of primary pericardial malignancy? A. Fibrosarcoma. 2011, 15:53-5. Jones B.V., ETAL vein of Galen aneurysmal malformation, diagnosis and treatment of 13 children with extended clinical follow-up. AJNR AMJ Neuroradiol. 2002, 23, 10-17-17-24. 61, D. Mesothelioma. Malignant mesothelioma is the most common primary pericardial malignancy. A causal relationship with asbestosis is uncertain because of low prevalence of this neoplasm. Mesothelioma may present as a well-defined single mass, multiple nodules, or diffuse plagues involving the visceral and parietal pericardium, and wrapping around the cardiac chambers and great vessels. Other malignant primary tumors include lymphoma, sarcoma, pheochromocytoma, and liposarcoma. Teratomas of the pericardium may also be malignant, and are most commonly seen in children. Pericardial metastases are much more common than primary pericardial tumors. Breast and lung cancers are the most common sources of metastases in the pericardium, followed by lymphomas and melanomas. Adam A. ETAL Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New. Fibrosarcoma B, pericardial angiosarcoma C, fibromyxoid sarcoma D, mesothelioma E, epithelioid endothelioma. 62, a 40-year-old man undergoes a CT-KUB for renal colic, which shows an incidental finding of an 8 mm lesion in segment 8 of the liver. Further characterization of this lesion with MRI shows it to be low signal on T1W and high signal on T2W. On the dynamic phase, it shows peripheral nodular enhancement with centripetal filling. What is the most likely diagnosis? A. FNHB, adenoma C, hemangioma D. Early appearance of hepatocellular carcinoma, HCC, E. cholangiocarcinoma. 63, of the normal uterus signal on MR, which is correct. Endometrium myometrium junctional zone. A. High on T2, intermediate on T2, high on T2B, high on T2 signal reflects the water content, which is highest in the endometrium, intermediate in the myometrium, and least in the junctional zone. Zone. Adam A. ETAL Granger and Allison's Diagnostic Radiology, a textbook of medical imaging, 5th ed. New York, Churchill Livingstone, 2008:. High on T2, intermediate on T2, low on T2C, iso-intense on T1, iso-intense on T1, high on T1D, iso-intense on T1, high on T1, low on T1E, low on T1, low on T2, high on T2. 64, a plain lumbar spine radiograph of a 45-year-old woman shows marked posterior scalloping of the vertebral bodies extending over several vertebral lengths. All of the following are diseases associated with this finding, except A. Marfan B, neurofibromatosis C, ependymoma D, achondroplasia E, hypothyroidism. 1219, Dannert W, Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011:1042. 64, E. Hypothyroidism. A common cause of localized posterior vertebral scalloping is increased intraspinal pressure secondary to an expanding mass. Widening of the interpediculate distance and alteration of the configuration of the pedicles are associated signs. Relatively large, slow-growing lesions that originate during a period of active skeletal growth, such as ependymomas, are most likely to give rise to posterior vertebral scalloping. Duralactasia is thought to cause posterior vertebral scalloping due to loss of the normal protection provided to the vertebral body by a strong, intact dura. Duralactasia classically occurs in association with inherited connective tissue disorders such as Marfan syndrome, classical, and Ehlers-Danlos syndrome. Posterior vertebral scalloping is also commonly seen in patients with neurofibromatosis, most likely due to duralactasia but also secondary to neurofibromas or a thoracic meningocele. It has also been reported in patients with as, in these cases, the development of associated arachnoid cysts may give rise to cauda equina syndrome. Acromegaly has been described as a further cause of diffuse posterior vertebral scalloping, probably because of a combination of soft tissue hypertrophy in the spinal canal and increased bone resorption. Wakely S.L. Chapter 1. Test Paper 1, Questions. 65, a 58-year-old man with facial fractures shows deformity of the globe on unenhanced axial CT, but it is unclear if there is an open globe injury. All of the following CT findings suggest an open globe injury, except A, intraocular, AIR B, lens dislocation C, scleral discontinuity D, flat tire sign E. SL. The posterior vertebral scalloping sign. Radiology. 2006, 239-26079. 65. B. Lens dislocation in blunt traumas. Ruptures are most common at the insertions of the intraocular muscles where the sclera is thinnest. CT findings suggestive of an open globe injury include a change in globe contour, an obvious loss of volume, the flat tire sign, scleral discontinuity, intraocular AIR, and intraocular foreign bodies. A deep anterior chamber has been described as a clinical finding in patients with a ruptured globe, and can also be a clue on CT. Cubble WS. Imaging of orbital trauma. Radiographics. 2008, 28, 617-20. E. Deep anterior chamber. 66 and 18-month-old child is brought in by her mother with complaints of visual problems. On examination, the left eye is of normal size with a whitish mass behind the lens. US shows a heterogeneous hyperechoic solid intraocular mass with retinal detachment. There are fine focal calcifications with acoustic shadowing. The appearances suggest A. Persistent hyperplastic primary vitreous B. Coats disease C. Retinoblastoma D. Toxocra endophthalmitis E. Retrolental fibroplasia. 1729-39. 66. C. Retinoblastoma. A small round cell tumor arising from neuroepithelial cells, is the most common childhood intraocular malignancy. Diagnosis is typically by ophthalmologic examination, prompted by leukocoria or white reflex. Retinoblastoma appears as an echogenic soft tissue mass with various degrees of calcification. The vascularity indicates tumor activity, that is, lesions are hypervascular at diagnosis and when active. Vascularity regresses with treatment. CT detects intraocular, extraocular and intracranial disease extension, excels at delineation of bony abnormalities, and readily depicts tumoral calcifications. On CT, retinoblastoma is characterized by an intermediate density enhancing soft tissue mass or masses, with varying degrees of calcification. Calcification increases with therapeutic response. The vitreous may be abnormally dense from debris, hemorrhage, or increased globulin content. Retinoblastoma is a heterogeneously enhancing soft tissue mass with various degrees of calcification on MRI. Lesions are typically hyperintense to vitreous on T1, weighted sequences, and hypointense to vitreous on T2, weighted sequences. The vitreous may be abnormally bright on T1, weighted sequences, because of increased globulin content and a decreased ratio of albumin to globulin that occurs with malignancy. The other choices are all differentials for white reflex, but do not show a solid mass with calcification. Cast SC, ETAL retinoblastoma. AJR AMJ Rentgenol. 2000, 175, 249. Fibroplasia. 67, a 35-year-old woman undergoes an X-ray in the A&E department with suspicion of chest infection. The X-ray reveals an abnormal mediastinal opacity, but no evidence of chest infection. Review of 2 old films done 2 and 6 years ago shows the same abnormal mediastinal opacities with no significant interval change in size, shape, appearance, or location. Judging by its location, the radiologist reports it as a simple pericardial cyst or spring water cyst. Which of the following statements concerning congenital simple pericardial cysts is false? A. They are homogeneous and well defined on frontal chest X-ray. B. They are most commonly left-sided. C. On MRI, they are low on T1W and high on